Migraine is a recurrent primary headache disorder characterized by episodic headache with neurologic symptoms. It is the most common neurologic cause of disability worldwide and the second most common cause of headache. Migraine affects approximately 15% of women and 6% of men annually. It typically begins during adolescence or early adulthood. The premonitory phase occurs hours to days before headache onset. Common prodromal symptoms include yawning, fatigue, mood change, and cognitive dysfunction. Aura occurs in 20 to 25% of patients and represents transient neurologic disturbance. Visual aura includes flashing lights, zigzag lines, and scintillating scotoma. Aura develops gradually over minutes and resolves within 60 minutes. The headache phase lasts 4 to 72 hours and is typically unilateral and throbbing. Pain is moderate to severe and worsens with routine physical activity. Associated symptoms include nausea, vomiting, photophobia, and phonophobia. The postdrome phase follows headache resolution and may last hours to 1 day. Common postdrome symptoms include fatigue, difficulty concentrating, and neck discomfort. Migraine triggers include altered sleep, fasting, stress relief, exertion, and hormonal changes. Alcohol, nitrates, and barometric pressure changes can also precipitate attacks. Migraine involves activation of the trigeminovascular system and neurogenic inflammation. Neuropeptides such as calcitonin gene-related peptide and pituitary adenylate cyclase activating polypeptide are released. Pain signals travel from trigeminal ganglion to trigeminocervical complex, and then to thalamus and cortex. Serotonin plays a major role in migraine pathophysiology. Triptans act as 5-hydroxytryptamine 1B and 1D receptor agonists to inhibit trigeminal transmission. Ditins act on 5-hydroxytryptamine 1F receptors without causing vasoconstriction. Dopamine hypersensitivity contributes to symptoms such as yawning, nausea, and hypotension. Typical migraine diagnosis requires headache lasting 4 to 72 hours with characteristic features. At least 2 features include unilateral pain, throbbing quality, moderate to severe intensity, or aggravation by activity. At least 1 associated symptom includes nausea, vomiting, photophobia, or phonophobia. Chronic migraine is defined as 15 or more headache days per month, with at least 8 migraine days. Acute treatment includes simple analgesics such as acetaminophen, aspirin, and caffeine combinations. Non-steroidal anti-inflammatory drugs, such as naproxen 220 to 550 mg twice daily, are effective. Triptans such as sumatriptan 50 to 100 mg orally are first line for moderate to severe attacks. Subcutaneous sumatriptan 3 to 6 mg provides rapid relief in severe migraine. Gepants block calcitonin gene-related peptide receptors and inhibit migraine pathways. Lasmiditan is a selective 5-hydroxytryptamine 1F agonist without vasoconstriction, but causes dizziness and somnolence. Dopamine antagonists, such as metoclopramide 10 mg, intravenously treat nausea and improve gastric emptying. Opioids are not recommended routinely due to risk of dependence and medication overuse headache. Preventive therapy is indicated for 4 or more migraine days per month or significant disability. Beta blockers such as propranolol 40 to 120 mg twice daily are effective preventive agents. Topiramate 25 to 200 mg daily is commonly used, but may cause cognitive slowing and weight loss. Calcitonin gene-related peptide monoclonal antibodies offer rapid onset and good tolerability. Onabotulinum toxin type A at 155 units is used for chronic migraine. Lifestyle measures such as regular sleep, meals, exercise, and stress management are essential adjuncts. Medication overuse headache occurs with frequent use of acute therapies, especially opioids and barbiturates. Clinical takeaway is to tailor migraine management based on severity, frequency, comorbidities, and patient preference.